not a fan of underwire bras, so we need to burn those guys.
Interesting. Tell us more. Tell us why.
It causes a lot of decreased circulation, and so many times there's congestion at the bottom of the breast, and many times right where the underwire would be. That's where we see more fibrocystic changes in that.
So it basically puts more compression around that area.
Yeah. Decreases
so that,
the circulation.
Your circulation, lymphatics, things can't flow.
Yeah, that's right.
Yeah, and like probably don't sleep in a bra.
Yeah.
Right?
Oh, heavens, I tell them whenever you can, don't wear one.
Yes.
If you know, and if the Amazon man comes, well, he's going to leave the package on the porch.
Hello, everybody, and welcome to episode 7 of the PHW Podcast. I get to be the lucky host today. I'm Dr. Kristen Marvin, and I have the honor and privilege of interviewing my dear friend and colleague, Joleen Zivnuska, women's health nurse practitioner extraordinaire. Like, I know that any of our patients and your patients listening will agree with me 100% when I say that you are truly a gift to so many people, and you're just like, the number one advocate for women and their health. And so I'm super excited to have you on the podcast today. We're talking about a really exciting topic, breast health, right? But before we get there, I know our listeners probably would love to hear just a little bit more personal stuff from you. So is there anything you want to share? Just tell us a little bit more about your background and like how you got into women's health.
I grew up on a cattle ranch around Manhattan, and always thought that I wanted to be a veterinarian until I got to K-State and found out you had to be a senator's daughter at that time. So that didn't quite work out. And I thought I really didn't want to try to go to the physician route, and so nursing was kind of where I went. And in my undergrad rotations, when I was in the birth rooms and stuff, I just thought it was one of the most boring things ever. So when I was young, it was kind of, I just jumped into the deep end and went into ICU, CCU, and thought that was a lot more action.
Stuff.
Yeah, a lot more action that way. And then I was in Houston working with cancer patients, and was doing charge on the 12-hour nights, and had one of our fellows gave me just a little taste of autonomy. And he said, just write your own orders. I mean, obviously talk to me about the big stuff, but write your own orders. I'll co-sign them in the morning. And so I thought, well, this is really kind of fun. I get to do what I want, order stuff for patients that I think is best. And so that kind of gave me a taste, and I knew some other friends that were nurse practitioners. So I thought, okay, this is what I want to do. So I came back to Kansas and I thought, I need to probably pick up some women's health, because that's before deciding what I wanted to do. And I actually hit Wesley right at the time when they were converting over to a tertiary care center. So many of the kind of normal vaginal delivery nurses were pretty nervous about having the sickest moms and babies west of Topeka come to the birth rooms. But me with Miss ICU, CCO,
you're like, bring it on.
Bring it on. And so they did. I was when I was working nights, and so they gave me kind of the most complex patients, which, multiple IVs, monitors, that didn't bother me. So that was kind of the beginning. So just right there at the birth rooms. And then Dr. John Evans, high-risk OB perinatologist, asked me to come work with him. So then I got to see more with high-risk OB, and kind of what was that beginning of what led up to that. What led up to the processes that they were having problems with. So have kind of done everything in the GYN world except oncology.
Yeah, very good. Well, you are certainly our go-to expert in the office for all things women's health and hormones and all that good stuff. How did you transition into more of the functional medicine side of things?
So I was working in a large OBGYN office at that time for 12 years, and was starting to see women that were on 10, 15 medications, and I just wanted to puke. I just thought, I'm not sure that it's really helping all that much. And I really got disillusioned with it. And I thought, I don't even want my name on this. Yeah. So my plan was to just get out and show my horses. That's where I was headed. One of the compounding pharmacists heard about it in town and so called me and said, I think you're really looking for functional medicine. And I even taught 4 years and was working with the KU's OBGYN residency program. I thought, I kind of know OBGYN. I have no idea what he's talking about with functional medicine. But he was encouraged me to go with him to a conference in Denver that a GYN was putting on hormones. And my husband's like, well, you're getting out anyway, so what do you got to lose, Yeah. So it was and Jan had done this with many other providers that he had kind of converted over to functional. So he had this down pat. And it was so amazing to be able to talk to him at suppers every night about what I was hearing. I was sitting in between a family doc and an OBGYN. And when they were talking about cortisol, we all kind of we're like, deer in the headlights. It's like, did you ever hear about this? Addison's and Cushing's, but that's it, right?
That's right.
So it was really the beginning, but it was absolutely very exciting. Yeah. And then in the land of OBGYN, we kind of have 6 to 8 drugs, and then we get into surgeries. And if the drugs and the surgeries didn't help, well, then it's all in your head. I mean, there's kind of that natural progression. And so I was really thinking about some of these women as I was hearing all of this, as far as, that's why she was responding that way. Yeah. And so that really piqued my curiosity to definitely be learning more.
That's amazing. Well, I know there's a lot of women out there, hundreds and hundreds of women that are like, let me find that person, Jan, and thank him for convincing you to stay because you've obviously helped so many women and bring so many sweet little babies, helped bring so many sweet little babies into this world too, right? Yeah. Okay, well, let's go ahead and transition then into the meat of our discussion, right? So all things breast health. Of course, as many of our listeners know, October is well known as Breast Cancer Awareness Month, right? Anybody who, is familiar with that and has seen the little pink ribbon knows kind of what that is. But I think, what I'm most excited about today is to give our listeners, especially the women listening, just some take-home actionable things that they can be thinking about when it really comes to supporting their breast health and their overall health, right? Because it's all connected. So, when you're working with a woman in the office and, maybe there is a family history or a concern for something like breast cancer, but even if there's not, what are some of the things that you first think about? What are some of the things that you're like, I'm going to teach this person this when it comes to breast health?
Just of realizing that it is a metabolic process. So, many women, whether it's a mother, when cancer is younger than 50, we think may have more genetic concerns. But again, we can have the genetics there, but we're not our mothers, and so that doesn't mean that that's necessarily going to be there. In fact, 5 to 10% are genetic in nature, but we're not doomed with that. And the genes may be there, the propensity may be there, but they don't get turned on, maybe unless there's more of a metabolic process from that. So it's just looking at all the other factors as far as what her insulin levels are, what is her weight, what is she moving, all those pillars that we talk about, is because that's where cancers come from. That it's not hormones. We want to pick on the low-hanging fruit and vilifize estrogen, and that's not where it's at. This is a metabolic process, and especially in the United States right now, it is disaster. I mean, it's really an epidemic of cancers.
Yeah, cancer and metabolic dysfunction, right? Let's, for our listeners, because I know you and I, we say metabolic dysfunction and we know exactly what that means, but maybe a lot of our listeners are kind of like, well, I've heard that term before, but what does that really mean? Maybe because our listeners are familiar with the pillars, let's kind of go through maybe a few of those and kind of point out some, areas. Because you mentioned great things like insulin. And I love, that point you made of, cancers really being just 5 to 10% of, or I should say breast
genetics.
Cancers, right? 5 to 10% are actually genetically driven.
That's right.
And, I remember a very sweet rep that we had for a genetic testing company, right? That when she would come visit and we'd talk about those things. And, I think a lot of our listeners are probably familiar with like the BRCA genes, right? And I just always remember, like, it always bothered me that, it was like, okay, it is arguably a very high percentage of women with a BRCA gene mutation that can go on to develop breast cancer, but it's not 100%.
No, it's not.
Right?
It's not.
So let's go back. Like, what are some of the big areas that you see with the pillars?
Yeah. So when we're looking at the pillars, and it just kind of starts out with trying to help ladies look at what is their purpose. And many times I truly believe women take care of the world and everything else in it. And
except themselves.
Yeah, that's true. That's so
or
true.
Ourselves are like last.
That's right. I have to prod them on that
I know.
part.
I'm like, I just had to dump that in there.
Yeah, it is. But it is true that because of that, we're the ones that are staying up with sick children, helping Aunt Martha, making birthdays, Christmas special. It's also why we have 80% of all the autoimmune diseases.
Yeah.
And so just realizing kind of what comes with that.
Right.
So in looking at the pillars, it's trying to kind of make that segue to them of their own individual health. So looking at, and the idea of trying to, what's my purpose? For some, that seems really pretty out there. But it actually helps us then to realize this is to be more disciplined about trying to make changes and actually to get their health in the best shape and to model to their family, to their children, how we take care of ourselves,
right?
As well.
Right.
So trying to have that be an encouragement to them.
Yeah.
Looking at just how we manage stress.
Yes.
So we all have it. And again, it was realizing the detriment of cortisol as far as the strongest hormone, but also the most inflammatory hormone in the body. And how do we manage that? Because most of us didn't grow up with parents who were therapists who could teach us how to manage stress. And so by hook or by crook, we just tried to get through the day and our to-do list the best that we can.
Right.
So of trying to, for some, maybe it is helping them learn other ways of, better ways of coping or what they can delegate out or say no to.
Right.
But realizing that cortisol, again, is that strongest hormone, but also the most inflammatory. And so when we're looking at metabolic diseases, obesity and insulin resistance, all those things are what is causing, kind of our epidemic of cancers and diabetes and cardiovascular disease and endometriosis, autoimmune diseases. All of that is kind of where the basement of inflammation going into the metabolic diseases. So how we manage stress and how we look at cortisol, because again, knowing that is also the strongest but the most inflammatory of all the hormones.
Right.
And especially with working with the sex hormones, they're the weakest.
Yes.
And so they can easily get obliterated by those stronger hormones, especially cortisol.
Right. So it really is important for women to understand that cortisol piece impacts not just, like only certain areas of the body. It's like it can influence how you're metabolizing your hormones.
Absolutely.
And the breast tissue is hormone sensitive tissue.
It is.
Right?
Very much so.
Yeah.
Very much so.
Yeah. What about from a nutrition perspective? Because that's certainly one of the pillars.
Well, we were meant to have whole foods, and these days we have invented a lot of kind of the Frankenstein foods, and so again, heavily chemically laden.
Yes.
And our bodies were just not intended to digest that and to be able to get the nutrients that it needs from it. So looking at not only how we're eating, but when we're eating, how much do we eat, all of that as in hoping to be able to get people back to eating whole foods again.
Right. Yeah. Yeah. So one of the many reasons why we recommend, if at all possible, try to choose organic, food that hasn't maybe seen any or quite as many chemicals, because we know that they're hormone disruptors, right? Endocrine disruptors. So that can absolutely affect our breast health. What's one of the most common, technically food related items that women might be addicted to first thing in the morning that could affect their breast health? It's a leading question, by the way.
Are you talking about coffee?
Yeah, I know this is like the most unpopular thing that I, sometimes bring up, but I think you could probably speak to that with how you see it impact women's breast health, right?
Right. Well, all the caffeines. So if it's coffee, if it's tea, if it's, some chocolates even, although there's good things, there's great antioxidants with a higher percentage good chocolates.
Right.
But of getting in the caffeines, which many times will stimulate fibrocystic cyst.
Yeah.
And maybe we're still trying to unravel densities, what's all going on with that, but part of that as well.
Yeah. And we'll definitely talk more about that later for sure. But okay, what about, a few other pillars maybe we haven't touched on? Actually, with detox, this kind of fits under detox. And we kind of alluded to this with the nutrition piece. But what are other ways that women expose themselves to chemicals maybe that you see?
Well, just in our healthcare products, our cleaning products, all of that. How we even warm our food, if we're microwaving in plastic, that it's coming in. All of those things of just looking at the house,
right?
And then many times our makeup, and especially for the United States. Europe has done such a nice job, a much better job of outlying a lot of our problems that are unfortunately allowed in our cleaning products or personal products. And so it really is kind of a buyer beware. Kind of the best thing we got for us in the United States is has California banned it.
Right.
I mean, that's kind of the only people
that's
that
like
seem
one
to care.
One thing California gets right.
Yeah, that's right. That's right. So, I mean, they are a little bit more out there than I think the majority of the rest of us in doing that.
Yeah.
So, but if we have a bunch of inflammation from cortisol, then many times the gut is not working as well as it should. It may not be trying to detox and get these aberrant chemicals out.
Right.
Many ladies, I think, honestly, just don't take the time to go to the bathroom. So they end up with problems with constipation, which then they're reabsorbing all those toxins that their body had gathered up and was trying to get rid of.
And hormones, right?
Hormones, yes. The estrogens, all those harmful hormones too. They just reabsorb them again.
Right.
And so definitely that can be, a big part of the inflammation with it as well.
Absolutely. Yeah. One big thing I often see with women is women love to smell nice and smell pretty. And so it kind of goes back to that, like perfume is a beauty product that is a huge endocrine disruptor. Right. And there's some natural options out there that women can look for. It's not like you have to go totally without, but even just being mindful of those things. And where do you spray your perfume?
Yeah, right over your thyroid and the breast.
So I think it's important for women to, recognize some of those things too, because it really does play a big difference, right? It plays a big role anyways. Yeah. So what about, are there certain, I think it's super important, right, that we touch on the pillars. We always want to focus on pillars first.
And especially sleep too.
And sleep, yes. I was going to say, do you want to touch on sleep?
Well, and I think because as women who are, trying to crank everything they can out of a 24-hour window, it seems like, then many times sleep may be one of those things that gets kind of lopped off.
Right.
But it's during that sleep is when we are restoring our immune system, 70%, which is in the gut. We are also creating our neurotransmitters, again, in the gut, majority of them in the gut. And so and we wash out amyloid plaque from our brains. So if women are not getting enough sleep, then many times that's when they're going to catch all the viruses or whatever that's going on. Right. Emotionally, they may not be in the middle of the road either because their neurotransmitters are not where they should be also. Yeah. So it's, again, that just restorative time, and when we are under the control again of cortisol and maybe not getting the sleep that we need, this body was intended to be in 80% of the time in parasympathetic nervous system of that rest and digest. But unfortunately, that's not how we live our lives. We are kind of in the opposite, to where we are 80% sympathetic of being able to just fight, flight, or freeze even sometimes. And so the detriment, again, of that strongest hormone, most inflammatory hormone, then for many women, they just have a hard time even shutting their brains off at night to be able to get into that good sleep.
Right.
So of helping them use some supplements many times. I use supplements to help a body learn a new way, and then seeing of what their what they're having them describe kind of their routine, what their bedroom's like, all that, if there's TVs in the bedroom but looking at brainstorming what their sleep patterns are like to try to help to have them learn a new way.
Good. Yeah, that makes a lot of sense. So essentially, I think the big take home there with the pillars is that, there's things that we have control over.
Right.
Some things we don't, right?
Yeah,
like I can't control that my neighbor sprays his lawn, or I can't always control technically, like, everything that maybe gets contaminated on foods, or, I can do my best, right? But that those things 100% influence breast health. A lot of times through, like you said, inflammation with cortisol, not metabolizing our hormones well.
Right.
Our gut not working well, we're not detoxing well. And then, sometimes just those things that we don't really think about that are exposures, like perfumes or beauty products or those types of things.
Right.
So,
and this body was really meant to move too.
Yeah. Exercise.
And,
we almost forgot exercise.
And so of being able to realize that it even helps us to be able to sleep. It's just kind of Mother Nature's natural way of a de-stressor for us to, and that may look different for each one of us, whether it's a walk with the dog or whether it's, doing more concerted effort of, CrossFit or something else like that.
Training, those types of things.
That's right. But we definitely, as we age, many women end up with little twigs as legs. And then the next thing is going to be a cane, and then a walker, and then a wheelchair and assisted living. So I'm going to try and do everything that I can to make sure that ladies don't go down that road.
Right.
And we definitely need to make sure that we are keeping that muscle mass and keeping building it, which is harder to do as we age. We have to work even harder at it.
Right. Are there any other than tools in the office sometimes that you'll use? I know you kind of briefly mentioned like certain supplementation to try to help support. Do you have any favorites that you want to share with patients?
When it comes to helping regulate cycles, Fin Balance is just one of my, I'm kind of basically really am a Debbie Downer. You kind of have to prove it to me because there's just so many bad stuff out there.
Yeah.
And, but when we first brought that in, my gosh, it went through 5 nationwide shortages.
Yeah.
I had women crying because they couldn't get it, and because it'll knock out PMS in about a month and a half.
Right.
It's good from even the teenagers with their heavy cycles and their emotions, and even before they, when they have 2 years of anovulatory cycles and those high estrogens.
Yeah.
Oh my gosh, 2 Fin Balance, you get your daughter back, you know? And it's, so that one definitely helps me with having ladies who have irregular cycles and to try to get back into regular cycles again. Very helpful as far as women who are trying to get pregnant. And then the sulforaphane that are in there, the calcium diglycerate, are definitely helping the pathways to prevent the estrogen-fed cancers, both breast and uterine cancers.
Yeah. So obviously it's really through that hormone metabolism support where you can really see that, how it can positively impact the breast tissue being hormone sensitive. Right. So that makes sense. One area I thought our listeners would find really interesting and that you've kind of shared with me a little bit about is just how our oral health maybe plays into this. So can you share a little bit more about that?
That's right. It really is one of those things that I think that we even have meridians from our teeth to the heart and to breast.
Yeah, to like certain organs in the body, right?
Yes. And so dentists have said that they have found cavitations, which is like like maybe at the bottom of a root canal, where there may be an infection there, but it's not painful, so ladies don't know it's there. But it's an infection that can be there, and then many times they may see issues like with breast on that same side. So the lymphatics actually drain out of that area down into the breast. Yeah. And so connections of seeing things like that in the breast, in the mouth, but then going to breast as well. I think there's the biologic dentist. They're saying that, the information that we got on fluoride was probably about 75 years old. And so of more concerns with neurotoxicity that may be there with it. Again, it's a metal that would normally be there. Mercury amalgams, again, if we see that there's heavy metals in the body, then many times that can be sources of issues with for people. So it is one of those things where it's looking at getting toothpaste, maybe that has things that will actually help us to remineralize teeth instead of tearing it down, not using the alcohol mouthwashes, but more friendly versions. And trying to keep our mouths basically in an alkaline state. So
like oral health. I mean, many people have probably been learning more about like the mouth has a microbiome, just kind of like, so some of those same principles can apply with the gut when we really think about it, with the gut. And if you think about it, your mouth is technically an extension of your digestive tract.
It definitely is.
But I think it's fascinating, right? That these certain, the teeth that we have, the individual teeth can actually correspond strongly with these organs that we have in the body.
Right.
So, and I remember years ago, I pulled up some research for a patient who had a history of breast cancer, who had mercury amalgam, metal amalgam fillings in the mouth. And believe it or not, there is some published research out there that shows that strong connection of something like breast cancer and having these things. And, when I share this with patients, and I'm sure some listeners are going to go, I have metal fillings, a lot of people do. And I think it's definitely one thing you can always bring up with your healthcare provider, especially your more functional medicine-minded healthcare providers.
Right.
Because there's still a lot of dentists out there that are like, don't mess with that. That's fine. But like you mentioned, we know that some of those toxic metals are definitely, associated with inflammation and brain health and obviously breast health too.
Right.
So
absolutely.
Yes.
Absolutely.
Well, let's transition a little bit into talking about like, what are some of the findings or just things that women should like pay attention to with their breasts, when it comes to, because that's probably a first step, right? Like helping women understand like, what is my breast tissue? Where is my breast tissue exactly? And what am I looking for? Those types of things. So,
well, part of, in fact, this just absolutely amazes me. ACOG has come out and said that they're not recommending self-breast exams and clinical exams anymore.
Interesting.
And that just blows my mind. I mean, I personally have found so many breast cancers. I can't imagine them saying not a clinical exam.
Yeah, that is interesting.
So I spend quite a bit of time in a well woman exam teaching ladies how to do a breast exam. So because most cancers feel like a rock. They're firm. They many times don't move. They're jagged like you would think a rock would be. And what's kind of dangerous about them is they don't hurt. And so many times they go undetected until maybe a lady sees a asymmetrical, lump, and it's like, well, what's this? Where if we have the little fibrocystic breasts, which are kind of like the little water balloons, those guys are tender. If somebody gives us an elbow, it's like, ooh, we know that. Yeah. And so if you weren't being intentional as far as doing the self-breast exams, then many times you wouldn't know that the cancer was there until much later. ACOG says that the reason that they're doing that is because it was producing too much anxiety for women. And I'm like, if a lady says, I don't feel anything, I can't do this, and it's like, okay, do you have a partner?
Sure.
And someone who can do that, or else, be able to come in a couple of times a year or something else. So they all know that if they do feel something, then, what your next step is get an appointment, and let us feel that with you.
Yeah.
So being able to kind of know what they're feeling. Yeah. If it's the fibrocystic, those guys are probably more responding to the caffeines, things like that. Fibroadenomas can be like a marble. They can be firm too. They're benign. But anything that's really firm, fixed, I mean, it needs some more imaging. It needs to,
If people are just listening to the podcast, when you mentioned that ACOG said that, they don't recommend those self-exams anymore because it causes too much anxiety, my face was that of great annoyance and skepticism.
Mine too. Mine too.
Because I'm like, well, maybe some of that anxiety is actually coming from just the unknown because women haven't been taught. You're like, who's teaching women how to do this?
That's right.
That's
right.
And so I'm going to just put on the record that I respectfully disagree with ACOG.
Yeah, that's both of us.
Yeah.
That's both of us.
Yeah. Yeah.
And I teach lymphatic breast massage. And so it's being able to try to help them learn how they can maybe get some of those fibrocystic cysts to go away, that as
Things
well.
like that.
So that they are checking. I think that's important.
Yeah.
And for those, most of them, it gives them empowerment that they know that there is something that they can do.
Right.
I am not a fan of underwire bras, so we need to burn those guys.
Interesting. Tell us more. Tell us why.
It causes a lot of decreased circulation, and so many times there's congestion at the bottom of the breast, and many times right where the underwire would be. That's where we see more fibrocystic changes in that.
So it basically puts more compression around that area.
Decreases
so that,
the circulation.
Your circulation, lymphatics, things can't flow.
Yeah, that's right.
Yeah, and probably don't sleep in a bra. Yeah. Right?
Oh, heavens, I tell them whenever you can, don't wear one.
Yes.
If you, and if the Amazon man comes, well, he's going to leave the package on the porch.
That's right.
And if,
that's right.
So, but if you can do it without it, then that's even better.
Okay. Okay. That makes a lot of sense. Yeah, those are good points for women. What if, well, first of all, is there anything else that women, should be aware of as far as just their breast, like discharge or any other skin changes or things, to look for?
One of, definitely, up to a year after stopping breastfeeding, ladies can have discharge, and that's totally normal.
Okay.
But if it's 2 years out or something like that, or beyond that, then that needs to be investigated as well. Okay. Inflammatory breast cancer is always almost an emergency. That's a very fast-growing cancer. The majority of all breast cancers have been there for 2 to 10 years. They're very slow-growing usually, but not that one. So, and it would be unusual. They would notice a reddening, red skin, and almost like a sunburn appearance, but that hadn't been there before.
Yeah,
they definitely need to get in and be seen.
Yeah. Well, maybe just for women out there who haven't really been taught how to do, how to examine their breasts, could you just give a few important pointers for women, of things like, is there an important time of when to check your breast tissue, especially if somebody's premenopausal, they're still having periods, stuff like that. What are just some of the basic tips that you teach women?
Well, the breast undergo changes with hormones just like our uterus do. And so it's preparing for that pregnancy again. So usually I encourage ladies to do it after their periods. Okay. They're not going to be as tender and the hormones are low. So that stimulation isn't there. And the perimenopausal ladies, they're kind of having periods every now and then. So it's kind of like pick the beginning of the month, it's going to be hard for them to know, but it's one of those things that women are the ones who know their breast the best. And so again, the idea of saying not to do that it's just nuts to me. And so many times I have them feel what I'm feeling, and so that they know what to look for. And if they feel like that area is getting larger or something, then they know that I definitely want to be there.
Investigate it further. Yeah, that makes sense. Those are good tips. Well, I feel like this is a really good, transition into maybe really, because I feel like we could go pretty deep on what are some of the just available and recommended screening tools that we have. I think like we were kind of talking about earlier, one of my big annoyances with the whole pink ribbon breast cancer awareness thing is that they kind of just emphasize that instead of all those wonderful things you just kind of talked through for us. So let's kind of go into all those different options and help women really understand what is out there, what maybe makes the most sense so that they can make an informed decision about how they want to screen.
Okay. I think that for years we have been told that mammograms save lives. And statistics are kind of walking back on that a little bit now. And so it is the concerns that we have with mammograms is that the compression, and it's really interesting. In the show notes, I'm gonna be talking about a documentary that Megan Smith made, and she's a journalist. She is she was a lobbyist on the Capitol, and she went after this, of what was going on with mammograms. And so she even came up with some things that I'd never heard of.
Oh, like what?
And she has, so
give us a preview so we get excited to go watch the documentary.
How we all kind of dread that compression, squeezing the breast?
Yeah, that's
so
common complaint.
How many pounds of pressure do you think that is that's applied to the breast?
I have no idea. My hope is that it would be as little as possible.
She says 45 pounds.
45 pounds?
Yes.
I mean,
in that breast compression.
I struggle to pick up a 40-pound dumbbell. And so 5 more pounds to that is what's added to the breast to compress it.
Right. And that's why women with implants, are discouraged from getting mammograms.
They don't want to burst the implant.
Exactly. But it's kind of like, why do we want to do that to normal tissue as well?
Right.
Yeah. And then, so it's kind of trauma to the tissue.
It's not kind of, it is trauma.
Yeah. But then we add radiation as we're kind of traumatizing the tissue.
Yes.
And so in doing that too, she got, she's a little persnick. I mean, she's a go-getter. Mm-hmm. Yeah. I'm excited. I ordered this, it's on Amazon. Cool. And so, we can, to be able to, but just as she was describing some of the things that she found by really pursuing it, and that many other radiologists didn't really even realize the amount of radiation that has been given to the breast. And they had to go check with their radiology physicist to find out, and the physicist was saying, no, she's right. That's how much it is.
Well, because I think so many women have just been blown off when they bring that up as a concern. They're like, well, it's not that much radiation. It's like getting on an airplane or some of these other things. And I mean, while some of that, may be true in the context of just how much, it's like, well, but does it really make sense, right? That we're
that's right.
compressing, traumatizing that tissue, and then we're intentionally giving that radiation when we've also kind of been told that radiation causes cancer.
That's so true.
So
that's so true. She also talks about Otis Braley, he's a medical oncologist, and he was the head of the American Cancer Society for a while. He's moved on from that now. But while he was there, he was even saying that the concerns with mammograms, and we got to find a better way. Yeah. So he was even acknowledging that as well. Yeah. Which is pretty exciting.
That is, I mean, that's big.
To think that's there.
And you're right. It is exciting. It's exciting to kind of hear people, not just, waking up a little bit, but then asking those tough questions and demanding better answers.
Yes.
Which is how we make meaningful change.
And it's just honestly, how long do you think that we would use mammograms if they were given to men on some of their tender parts? That compression?
That's a very good question.
Yeah. It would be gone, right? Capitol Hill would have it out of the way. There would be funding like you wouldn't believe.
I'm laughing, but it's true.
Yeah.
Unfortunately.
I mean, but we think that we're doing our duty, that, that's how we're monitoring our health. We're trying to prevent cancer when actually, again, it's the pillars, it's the metabolic, it's those choices.
Yes.
And, and I'm going to digress just a second because there's one other big piece. I think that, getting cancer is many times the lifestyle choices that we make, but sometimes it's life events as well.
Oh, yes.
And so with that, what I'm talking about is traumas, whether it's big T or little t traumas that are there. And I'm so thankful for the mind-body therapists who really are experts with trauma to understand this. And many times I see that coming in with women who, when I'm asking them about their stressors, I'm trying to see, do they have anxiety, things like this. And they're telling me everything's wonderful. I'm doing great. I don't have any problems. But yet I'm looking at biological markers like reverse T3, like oxidative stress, things like that are telling me the opposite. And so those things are going to go elevated when there is a lot of anxiety or inflammation, basically. And so of being able to, again, try to help them learn a different way.
Absolutely.
And many women don't even realize that they have trauma, but their bodies are telling me they do. They have really heavy cycles. It is never normal to have
Right.
heavy cycles.
Right.
We want to rationalize that away, but it is never normal.
Right.
And I can tell you all the physiology behind it. But that's where many times being able to show women those independent markers is how I can get them to see that maybe there's something different here, because the body is still going to respond to that trauma, even though they may have disassociated from it, they may have swept it under the rug. Their body's still responding to that.
The body doesn't lie.
It doesn't. It doesn't.
It keeps us
once
honest.
once you know how to listen,
That's right.
Once you know
That's
how to
right.
listen,
That's
but
right.
many times we don't.
Yeah.
We're busy. We just,
Yeah.
It's like we got a migraine. We don't wonder why we have a migraine. We just take a pill.
Yeah, take
you
a pill.
know, and we keep going.
Right.
So that is, and I personally have found probably what I would say were 5 either breast cancers or uterine cancers that I feel like were caused by trauma.
Yeah.
And so, I mean, so if I'm seeing that, I
Right.
mean,
Yeah.
it's definitely out there.
Yeah.
And I think that that's just a whole nother source of when we look at some of the things that can cause cancer.
Absolutely.
And all of our metabolic goop that we are into these days, we're seeing cancers in much younger, in teenagers and in the 20s. It's not just the elderly and ladies in their 60s anymore.
Right.
So of being aware of how that this is, all
Plays
affecting
in.
it. Yeah.
Right.
And we've
Right.
had some other maybe immune system disruptors in the last several years that may have added to some of this as well. But it is the fact of it is that we truly do have an epidemic with metabolic issues, and cancer is right in there with that.
Right, right. So yeah, it's not just physical trauma to the breast that unfortunately happens with a mammogram, but it can also be, like you said, big T and little t traumas too.
Absolutely.
The emotional part that, we call emotional is very much a piece of our whole system.
Yeah.
And so when we are, truly taking a holistic, a whole person approach, we 100% have to take those things into consideration. Right.
Right.
Okay. So I can already hear several of our listeners going, mammograms, maybe these aren't the greatest thing. Maybe I shouldn't be doing this. Surely there's other tools women can consider.
Yeah,
So
right,
let's kind of talk through, what are some of those things that are available? What are some of the obstacles? What are maybe some of the, both pros and cons? Because no test is perfect, right?
Right. Not yet. Not yet.
Not yet.
Not yet. Yeah. So in the works.
Okay.
But not yet.
We'll get to that.
So it is when we look at thermography.
Yes.
So it is detecting heat, which is usually inflammation.
Temperature, right?
Right.
It's measuring temperature.
And so of realizing what that is looking at. So that's why you have to go in and if it's cold outside, you have to warm up. And sometimes they have you put your hands in water and all this kind of stuff. But a concern I have with that too is just the penetrance of it. So if you have smaller breasts, that's probably going to be okay. But I question the depth that can really go in detecting heat.
Yeah.
Dr. Jen Simmons is was a prior breast surgeon. Went back and got her functional certification through IFM, and she is now a breast oncologist. And she's written a book, The Smart Woman's Guide to Breast Cancer, and all these things are going to be in the show notes.
Awesome.
And she also has a podcast called Keeping Abreast, which I have just lived on. I mean, it's really just an amazing resource that we have that, and especially an oncologist that is specializing with breasts. That's just so exciting to me.
Very exciting.
She's the one that says that she does not believe that thermography should be done by itself, but it should be done also with ultrasound. So putting those two together right, gives you a little bit better idea.
Yeah.
Ultrasound is really good as far as being able to show us whether a mass is cystic or solid. But again, not all solid ones are cancer.
Right.
The adenofibromas, those guys they're like little marbles, but they're not cancer. But it goes, and so there can always be shadows or finding things that, don't pan out or don't, that's some of that of where we can overcall things, whether it's mammograms, ultrasounds, MRIs, breast MRIs do as well, which I've always thought of those guys as, okay, that's where we go to see if it's invasive or not, or if there's metastasis. But yet it really has limitations as well. It's no radiation, but it uses gadolinium dye, which is a heavy metal that is accumulating in the body, especially they're watching it accumulating in the brain. The studies so far have seen not to see that it's causing problems, but it's a little bit unnerving, that we're putting a heavy metal in the body.
Yes.
That we really can't get out. There's detox protocols for anyone who needs like CAT scans or even mammogram. So, those are things we have at the office if anybody's ever interested in that, because people, especially if you do have a cancering diagnosis, there's going to be probably a lot of those studies. But it's things that we can do even prior to and then after to try to help with the detox part of that.
To support.
Right.
Good. Well, let's summarize that a little bit for our listeners, because I feel like there was a lot of really good information in there. So, and we could even like present it as kind of a story, like the typical timeline, right, that a woman might go through. I think, you know this better than I do off the top of your head, but I think still the general recommendation for screening starts at as early as age 40 for just general. We're not talking about women that have a strong family history or anything like that.
Right.
But at least sometime in that 40s decade to get at least a baseline. Right. So women would maybe go as early as 40 to get a mammogram, and they get a mammogram. And we kind of summarized, some of the potential pros, although not many of the pros really stick out at the top of my mind. But with that being said, the cons would be, like you said, we're compressing tissue, and we're not just squeezing it. We are compressing with 45 pounds even of pressure. And then we're radiating the tissue. And my understanding too, with the mammogram, where it's one of the potential just downsides of where it's lacking, and we're trying to image the breast, right? And talk a little bit maybe about how like the densities, like we mentioned it before, but like how common are densities for women?
So again, some are saying that it's up to 50% in women who are greater than 40 years of age.
Okay.
When you look at a mammogram with a woman with dense breasts, it's a whiteout. And so I had a radiologist explain it to me. It's like looking for a snowball in a snowfield.
Yeah.
And that's why mammograms miss 30% of all cancers in dense breasts. And so again, looking for some other kind of way, another method of being able to imaging breasts that is going to be able to not have the negativity to that and be able to actually
try to see it,
to image it.
Right?
Yes.
Yeah. I had a radiologist once tell me that really a mammogram only sees well in women that just arguably have very fatty breast tissue.
That's very true.
Right.
That's
so
true.
so
they're black. A mammogram on those breasts is just pitch black.
Yeah. So that then like maybe an abnormal density might show up, or you could see that better.
Right.
But if like you said, up to maybe 50% of women 40 and older, which those are predominantly the women getting mammograms, right? Have dense breast tissue, then the mammogram's having a hard time even seeing through that. I love that analogy. Looking for a snowball in a snowstorm. That'd be very difficult to do, right?
Yeah.
So then, I think that probably contributes then to the data that we have out there that's been published that shows, that women, when it comes to mammogram, what they may do is actually overdiagnose women compared to actually helping a woman like with something like a breast cancer, an actual true breast cancer diagnosis.
Yeah.
So then, okay, what's, they're going through this mammogram. Let's say it's it's up to 50%. So maybe 1 in 2 chance that you're that woman who has breast densities and the mammogram maybe sees something. So the next recommendation is...
Well, then they many times bring them back for a 3D, which is even a higher radiation.
Higher radiation.
Yeah. And so of being able to see again, can they get a differentiation on that?
Yeah.
Then many times of going to ultrasound. But here's kind of a kicker with density. So I always hate it when the experts don't agree. I want to know black and white.
Yeah.
It's just easier on my
It's
brain.
easier that way, isn't it?
It is. So ACOG says that if you have density, it doesn't matter. You don't need any more imaging. You're done.
I'm disagreeing a lot with ACOG on this episode.
Well, it's interesting. They are the one discipline that is sued the most often, unfortunately. If you've got a bad baby, it's just watch out, that type of thing, whether she's on crack or cocaine or not.
Yeah.
So it's fraught with that. But I think, frankly, it's a CYA thing on their part. The other people have other entities have said that no, we need to look further. We need to try to see what else we can find. So usually anybody with dense breast is going to end up with an ultrasound as well. There's disagreement on what causes dense breast, and so some have said you're just born with it. There's nothing you can do about it. And when I think about that one, my mom had breast cancer at 37. So I started having mammograms at 30, and I already had dense breast. I wasn't on birth control pills, didn't have any higher estrogens, was average weight, all of that. But I had dense breast. So I thought, well, that seems to fit,
Maybe, yeah.
And I've been watching that with ladies who have mothers with breast cancer, and it is true. Many of them do have dense breast. So my whole thing, though, is, and others have said, okay, it's estrogen dominance is what causes that. So again, the fem balance, the detox, and if they're on hormone replacement, of keeping that, in the middle of the road, we're not, going too high, too low. We're trying to manage that well. Of being able to not cause more problems. But the one thing that frustrates me is when they're saying there's nothing you can do. So I'm kind of using myself as a guinea pig on this one. And for all the ladies that I've seen, I'm keeping track if they have heterogeneously dense breast or category 5, the worst is extreme dense breast. And I'm writing down when they had their mammogram, how old they were, all that kind of stuff. And one of the things that I'm questioning is whether iodine could be a part of this. And so of being able to use some iodine in castor oil, using it topically. So I've got my iodine level and all this. And so I'm kind of just marching on to see what's going to happen.
Yeah.
And I signed up for our Her Scan ultrasound in November and seeing if maybe they can see a difference of where I've always been. But just to see, I'm not satisfied with just saying there's nothing we could do.
Yeah, I don't like that answer either.
Yeah.
I think it's a lazy answer.
And there's some things with iodine with fibrocystic, but nobody's looked at density. So this is just kind of our own little in-house
research
experiment. Yes. To see if maybe we can make things better.
I love it.
Yeah.
Well, I think back to ultrasound, when that, if a woman gets to that point, likely because of a density or sometimes some type of abnormal mass, the frustration of sorts is that, especially for those women that come in and they're like, I feel something and it's right here, where women, if I understand this correctly, still it's women over the age of 30 cannot just go in for like a diagnostic sonogram.
That's true.
The facilities, at least in our area, the outpatient imaging facilities all require a woman in that scenario to have a diagnostic mammogram first. Yeah. And then they almost always end up doing the sonogram anyway.
Yeah. It's honestly the American College of Radiology that sets that standards.
It's their standard. I still have yet to hear, though, a good explanation for why that is. It's just the way we do things.
Younger breasts are more dense.
Yeah.
And so I think they know what they're up against, and it's like, no, we're not going to go down that road if we have to.
Yeah.
What I'm frustrated with is had a lady with known dense breast, and so I called out to see, can I just send her automatically just a mammogram and an ultrasound?
Yeah.
And I was told no, that she had to have a mammogram first, and then the radiologist would determine whether she needed an ultrasound. And to myself, I'm like, but it misses 30% of the cancers. Why are you even legally putting yourself in that position,
Right.
But there are other options as far as some practices in town that are having ultrasounds, and so we could do that, with our patients to go to another places.
Another
and
option.
Yeah, this facility is kind of doing some remodeling right now,
so they're not ready.
They don't have to be a patient there to do it, so we could do that in the future.
And like you mentioned, coming up this November, we're going to be the host site for a company called HerScan. You can learn more information on their website, herscan.com, and even find scheduling options for the days that we are hosting. They have, it's an independent not an independent radiologist, but an independent sonographer coming in. Everything is through them. It gets read by a certified radiologist. You get the report, and it can be, it's actually considered just a screening sonogram. Which again, I think is, we can certainly admit, just like mammograms, as far as sonograms aren't perfect either. Right.
That's right.
So no such thing as a perfect test, but I am thankful that at least some options do exist out there that women can think about, because some women, frankly, and I certainly don't blame them. They're just like, I'm not going to do that. So then they just don't get any screening at all, frankly. And I don't know if that's necessarily the best option for women either.
Yeah.
So
it's very true.
I'm thankful then. And then, you also mentioned the MRI. So sometimes I think my understanding is, and you definitely correct me if I'm wrong here, but an MRI is usually a next step if there is maybe something more serious going on. And like you mentioned, while MRI is positive in the context of no radiation, they unfortunately have to use a contrast dye agent, the gadolinium, which is, like you said, a heavy metal that accumulates. And we may find that probably isn't a great thing for the body either. So kind of the pros and cons of all those things. But I'm not familiar with a lot of women really trying to just seek that out as just a basic screening.
No, I think in May I had an hour-long conversation with one of the radiologists from a facility locally, and asking what's the plan for density, what are you guys going to offer? And she was saying that probably is going to be either ladies can choose between an ultrasound or an MRI. Obviously there's a big financial difference in those. And so I think most women are probably going to opt for the ultrasounds.
Yeah. Yeah. And then maybe you kind of dropped a little hint about maybe some technology that might be close to perfect at least. What are just a few maybe hints you can share, just given that that's probably not an option available for most women, especially our listeners in our area? What little hints can you share? What might that look like?
Yeah. Well, thankfully there is emerging things out there, and of not having radiation and not having compression.
Yeah.
And so it's pretty exciting. To be able to know that we have something that looks like it's going to be a lot of what we really want and need. Yes.
Awesome. That's great. That's great.
Yeah.
Well, as we start to wrap up a little bit here, is there anything else that you can think? I know you always have so many wonderful things to share, but definitely throw that in there now if there's anything else you want to share with our listeners. One of the things that I'm
excited about is to see kind of this trend changing. As far as historically, oncologists have just been dug in on if you have especially estrogen-fed breast cancers, then there's no hormones for you. And, we're even seeing it in teenagers now, in 20-year-olds, in 40-year-olds. And I have seen a lady that was 40 who had a total hysterectomy, and I met up with her in her late 50s, and she had severe osteoporosis. She was a master gardener, and I was like, don't you dare dig up a rose bush.
Don't fall over.
So we know what's going to happen if women don't have estrogen. Yeah. And so that has been just kind of the rule of the land, and so it's been trying to help women with vaginal estrogens, of being able to help sometimes even like with the fem balance, because it does have plant-based estrogen, progesterone. But it's more and more, I'm very thankful for providers who are willing to give back low dose, add back hormones. And so women can, the sexual dysfunction can be dealt with. There's always been the estradiol cream. Way back in the day, that wasn't even something they wanted to use in town. And I did studies looking at blood levels, to tell them, no, this is okay. You know? So then that got calmed down and we could use that. That was all right.
Yeah.
But of actually being able to give them back hormones of testosterone. And again, when you realize what cancer is, it's not estrogen.
Right.
And we have villainized estrogen so much. It's the low-hanging fruit. You don't need to change your lifestyle. You just need to not have estrogen.
You just need to avoid a hormone that basically is giving you life.
That's right.
I feel like we need to make T-shirts and bumper stickers that say estrogen does not cause cancer.
That's right. I would go for it. I would love it.
Well, and of course, you know, this could be a whole separate podcast in itself, but I think it's still worth mentioning briefly that probably a lot of that stemmed from the awful Women's Health Initiative study in the 90s.
Oh, yes.
That incorrectly demonized estrogen.
Yes, it did. It did. And I lived through that.
You did.
I did.
I was alive during that time too. I was just younger.
It was a tsunami who hit our OBGYN office.
I bet.
And it's really frustrating because I've been a coordinator of many clinical trials, FDA clinical trials, and the gentleman that ran that one really did have a vendetta. He told many people ahead of time, I'm going to stop he was a cardiologist. His belief was hormones were not good for women. And so he was like, I am going to stop this hormone train. And so it's all been walked back now, but nobody heard that.
Yeah.
Nobody read that they came out and said,
not a
no,
catchy
headline. This was not, it was not true.
Yeah.
So worst hormones out there as far as equine estrogens, 50% of that does look ours, but the other 50% of that is just equine, pregnant mare's urine.
Yeah.
And then the worst progestin, Prevera.
Right.
So no wonder that we had some issues, and there were a lot of concerns with that study as well. But it got leaked out, which is what you never want in a clinical trial, but some people had intentions. And so then many physicians really got scared. We even were asking the Premarin rep, what is going on? She says, I can't even find out. And so it was just kind of a panic mode of cold turkeying women off hormones. And I mean, they were flooding us with, can you help me? Can you help me? You know, I mean, it was just really a very sad time.
Right.
So that has stuck, you know, all these many years later. And it's just, I still hear it, you know, that a lady will say, my doctor told me that I don't want hormones because that's going to give me cancer.
Right.
And so it's still being repeated even today. So that's some of what we're up against, you know, with it.
Yeah.
But thankfully, hopefully we can turn the tide on that. Ladies who are estrogen receptor negative, it never was an issue for them. And again, when you understand what causes breast cancer and you understand we've got to go after the metabolic processes that allowed this normal response to an abnormal metabolic condition.
Right.
Okay, we can do that. And she can have hormones. So that's very exciting to me. I mean, it's just still kind of in its infancy, you know, stages, but, you know, it is one of those things that Avram Blooming was a physician that wrote Estrogen Matters ages ago.
Yes.
And he was just saying, no, what we're doing to women, this is hideous. And he even had a daughter who had breast cancer, and he said, absolutely, I gave her estrogens. He's probably the only medical oncologist, you know, until Dr. Simmons that I have heard who has said that. But she's really campaigning hard for it. And on her podcast, Keeping Abreast, she does interview other providers, and some of them do telehealth. And so if there's not somebody in your area that does it, you know, there are ways to get around that as well.
Yeah, there's ways to find that, right? Access to that, which is so important.
That's right. So that's an exciting thing. And they, so it's also Megan Smith who did her documentary on the boobs. She also did another one on alternative cancering methods. So that's going to be in the show notes as well.
Great.
It's currently on YouTube. Never know when it may be taken down because
may
it is
not be.
alternatives.
Right.
But she went to Mexico and a lot of different other places to document that of what people were doing that was working. You know, besides chemo and radiation.
Yeah.
So
Amazing. Well, what else? Is there anything else you feel like you want to share for this episode?
I think that's mostly it.
Amazing.
Yeah.
Well, thank you so much for joining us.
Absolutely. Thank you.
Again, like you are just a gift to our clinic and our patients and so many women. You've positively impacted so many lives, and we're just so thankful for you. And so thankful for you to share your knowledge today with our listeners. And just to reassure our listeners, we'll definitely be having Joleen as a frequent flyer, repeat guest on the podcast. So don't worry, we'll come back with lots of other amazing women's health, hormone related topics that we'll cover. But of course, we thought breast health was very appropriate for the upcoming month of October. And I think we can arguably do it a lot better than that pink ribbon organization.
That's right. That's right.
So thank you everybody again for listening. And don't forget to check us out on all of your podcast streaming apps, even on YouTube, and check out some of our other episodes. And we look forward to you guys joining us again soon. Thanks.